Okay, hi everybody. Welcome to Grand Rounds. Thanks for coming. I know it's busy on faculty as usual. Thanks for joining us for your lunch hour. Today I have the pleasure to introduce Dr. Alfred. You guys probably know him already because one of our colleagues done it outside of Israel. I'll shoot it into the talk that he gave at SHN. If any of you guys were able to see that, but it'll be an update on clinical guidelines, which will be very helpful for us since we're also busy ourselves. So thanks very much for today.
Thank you. So thank you all for having me. It's a pleasure to come up and speak to you all. I'm going to cover, so the title of this talk is a little deceptive because it's top new guidelines every hospitalist needs to know in clinical practice. But the timeline was actually, because it was the first time this talk was given at SHM, I took the liberty to go back to 2017 and up to 2019. Sort of didn't include too much from 2019. But I think these are all still very good guidelines. I'm here going to discuss the relevance of the guidelines to the clinical practice of hospital medicine. We're going to talk about really the strength and quality of the data of each guideline and the recommendations. And we're going to apply the recommendations to some potential medical cases, i.e. cases I wrote. So those are sort of our learning objectives. Just so you're all aware, how did I find these articles? Wasn't happenstances. It may seem like that, but it wasn't. So I did a literature search with the medical librarian down at Beth Israel for all guidelines published in the time frame. I reviewed the title and abstracts for content, selected guidelines based on their relevance and interest to the daily practice of hospital medicine. I'm going to be very blunt. Someone else may have chosen some other guidelines. You may have done that. You may think they're not as relevant. I'm not going to disagree with that. It all depends on sort of our own clinical practices, and then what do we each see day to day. And there may be some local and regional variance in that causes some practice guidelines to seem more important than others. Because this talk was initially designed for Hospital Medicine 19, I took a look, and so I stayed away from some topics that were covered there in other dedicated talks, such as stroke and CHF. These are also very large guidelines and really do deserve talks unto themselves. The purpose was to review the guidelines and the quality of the recommendations. I'm not here to dispute them. If you're someone who doesn't like guidelines, views it as cookbook medicine, thinks all your patients, thinks all your patients are different, I can't control that. I'm just here to present them. I'm not here to dispute them, right, wrong, or the other. Caveat, if you don't like guidelines, then probably you might want to leave now because you're only going to get angry. So, without much ado, our first case will be a 72-year-old man who comes to the hospital after falling at home. He's unable to walk due to back pain and is admitted to the hospital for pain control as well as possible placement in a rehab facility. He's diabetic and states his physician retired, quote, a while ago, end quote, and he has not seen any doctor in a year. He believes he was on something called metabolormin. His sugar is 305 on a point-of-care glucometer. The nurse asks you, what regimen do you want to start for his diabetes? Think about it for a minute and say. And you can raise your hands if you want, or we can just sort of can internally vote, whichever you want. So A, who's going to choose A? Long-acting insulin with fixed pre-meal, short-acting insulin only. B, short-acting insulin, sliding scale only. C, long-acting insulin with fixed dose pre-meal, short-acting insulin, and short-acting insulin as needed. And D, let me look up that new metabolormin drug, and I'll get back to you. So, this is the 2018 updated inpatient diabetes care from the American Diabetes Association. There is the reference for those who want to go and look it up. So, just a nice little picture here of diabetes. So I used the one with the little words there, so you didn't think it was just a picture of cocaine or some other powder drug and a syringe. So the ADA. I'm going to go over this because they're the only ones that use a different grading scale. They use their own grading scale. We'll review the grade methodology at a later point, which is what all subsequent guidelines use. They basically said level A, which is clear evidence, well-conducted generalized trials that are adequately powered, evidence from well-conducted multi-centered trials, meta-analysis incorporating ratings into the analysis, and still a lot of guidelines have come up to speed saying there are some non-experimental evidence that meet sort of all or none criteria based on the Center for Evidence-Based Medicine at the University of Oxford. B, supportive data from well-conducted control style studies, supportive data from well-conducted case controls. Level C, evidence from poorly controlled or uncontrolled studies, randomized controlled studies with major flaws based on the reviewer's view of the study, observational studies with high potential for bias, case series or case reports, or there's conflicting evidence. Level E is just expert opinion or consensus of clinical experience. So without much ado, the guidelines. So the first guideline I want to address is that they do recommend at a level B of evidence that we should get an A1C on all patients with diabetes or hyperglycemia, if not previously diagnosed with diabetes, with blood sugar of 140 milligrams per deciliter, if not done in the previous 3 months. They also say, based on expert opinion or consensus, that we should use well-validated protocols to deliver our insulin. No evidence, but I think we all sort of agree with that and probably do that already. So how and when should we do it? What should we target? So at a level A, they're saying that insulin should be started for patients with persistent hyperglycemia over 180 milligrams per deciliter, and that our target range should be 140 to 180 for most patients on the clinical wards. Not in the ICU, this is outside of the ICU clinical wards. They are saying that more stringent target of 110 to 140 may be appropriate for selected patients. For those familiar with this database, the Nice Sugar trial is where they derive much of this from, and it's sort of been out there for a while. The idea of level C, though, that we should use tighter control is a little more controversial, but there may be some patients who really do fall into that, so you should be aware and sort of look for those patients. They are coming out very strongly, level A, that basal plus bolus correction insulin with additional nutritional correction insulin supplements is preferred for non-critically ill patients. Sliding scale, strongly discouraged. Right, so that I think is the big one that maybe is a change for some of you. Maybe it's not. This is essentially saying that long-acting insulin with a set pre-meal insulin as well as additional coverage for elevated sugars that you have not accounted for before or for dietary changes or something like that. So that's really where they're recommending. No more sliding scale, basal bolus, pre-meal, long-acting, with correctional in addition, and then adjusting going forward if you are consistently using adjusting level insulin. So you say, well, what about our patient who's on a tube feed, or you've had to put an NG tube down for nutrition because they're critically ill and maybe a little encephalopathic right now? They're just saying use basal insulin as based on the needs, and that you should also have corrective short-acting. They do get a little deeper into the process here. In the first 24 hours, you may have a little difficulty and really need to adjust, but that really we should be doing some weight-based calculations, putting people on some standing insulin, and then giving additional insulin for needed for those that are not eating for themselves. What about non-insulin therapies, oral agents? They really say, they come out and strongly say they're not giving it any guidance, because they think this is an area of active research. As some may know, there are individual agents that have risks of their use for prompting ketoacidosis in hospitalized patients or patients that are sick enough to be hospitalized. And there are others that carry risks of heart failure, so maybe in our decompensated patients that are in the hospital that are undergoing some other active medical therapies, we want to stay away from these. What I am taking away from their guideline, and the bottom one is mine, which is you really need to review any individual agent. What's its side effects? Is it appropriate to use here? Because there may be times it's appropriate to get people back on their oral regimens as you're preparing towards discharge, but they stay away from any guidance. Hypoglycemia. So this is level E, mostly because there's no real research where we make people hypoglycemic and figure out how we're going to rescue them, right? There's no blinded, double randomized controlled trials on this. What they do say is that we should have clear protocols for how we're going to address it, prevention and treatment, as well as they recommend that we track these episodes so that eventually we can look for patterns or root causes, and that our regimens should be reviewed and changed if we find patterns to prevent blood glucose of less than 70. Transitions from acute care to the non-acute care setting. So a level B, a lot of sort of controlled trials or case controlled, but not randomized and not what they consider level A trial evidence, that we should really institute structured discharge plans tailored to individual patients. We need to do med reconciliation. I think we all agree with that. Good idea. Establish a follow-up plan. I don't know anyone that can argue with that. Educate our patients on new medications. Really sit down and talk to them now. Don't sort of say, hey, it's a new medicine. You'll get a pamphlet from the pharmacy. You should read it. We should probably be a little more active. They come down on that. And review the understanding of the disease, complications, and medications with each of our patients, because this is a great time to take a couple of minutes to do that at discharge, really make sure that they understand how whatever brought them to the hospital, if not related to their diabetes, is interacting with their diabetes, and ensure that they have an active knowledge of their own disease. So in the end, answer C, the long-acting insulin with fixed-dose pre-meal short-acting insulin and short-acting insulin as needed is what we would say is the level A sort of answer for this. I'm still very attached to metabolormin, but, that's just me. So, all right, next case. So, in the past, I've gotten tied up in questions, so I'm going to wait for all questions at the end, and then feel free. 35-year-old woman recently treated for a dental abscess with amoxicillin clavulanic acid 3 weeks ago, now comes to the hospital with watery diarrhea happening 4 times a day. She says she thinks it was the fiber shake she had yesterday that started this. She has a temperature of 100.1 degrees Fahrenheit and a heart rate of 98. Her abdomen is mildly tender, and she has hyperactive bowel sounds. Her white blood cell count is 11,000 with 87% neutrophils and 4 bands. CAT scan shows colitis without obstruction. She is admitted for further management. After asking for stool studies with cultures and C. diff test, you order A. You decide to treat her with ciprofloxacin and metronidazole for possible bacterial colitis, because you're still not sure what it is. B, metronidazole for a diarrhea that concerned that this is early mild C. diff enterocolitis. C, oral vancomycin to treat for possible C. diff. Or D, tell her to lay off the fiber shakes and offer some Imodium. So we'll go on. So this is the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America's clinical practice guidelines, Clostridium difficile infection. It was printed in Clinical Infectious Diseases, Volume 66, in March of 2018. It's been making the rounds, been talked about a bunch, but still, sometimes we might not have heard of it. So, poop. Right? That's what we're talking about here. Sick poop. It's got a little thing on its head, the thermometer there. So, the grade recommendations. I told you they were coming, and here they are. So what is the grade methodology? Well, it's the grading of recommendations, assessment, and evidence. So what you can see here, there are 2 components. They've sort of, as opposed to just saying level A, level B, or as some organizations say, 1A, 2B, 3C, right? They just give strength of the recommendation and then what they consider level of evidence. For the strength of the recommendation, how do they base this? Strong. There's either strong or weak. Weak is sometimes called conditional, and you will see conditionals in this. Strong is desirable outcomes, increased longevity, decreased mortality, resolutions of symptoms, improved quality of life. Weak, maybe some undesirable outcomes are sneaking in there. Maybe longevity is not increased, but it's decreased. Maybe there's complications. Maybe there's just some short-term minor side effects. And then the dreaded rare but serious long-term adverse outcome. Ratings of the evidence. So it is a nuanced approach. They don't just sort of lump all studies into one category, good, bad. They do consider the study type. They do consider randomized control the highest level, observational the lowest. Case series fall here. They actually say expert opinion doesn't even count in their rating system. Shouldn't be rated. It's expert opinions, not evidence. I know some experts might not like that, but that's this methodology. They actually, though, say on top of the study type concern, you need to balance the quality of the study. So just because it's a randomized controlled trial doesn't mean you want to give it your strongest or view it as the highest level of evidence if there's a lot of potential bias, if there are a lot of limitations, if the authors don't account for either of those. Non-randomized experimental trials without important limitations can be considered for high quality. And so what it really does is it requires close assessment methods to the studies that you are looking at. So for this particular study, one of the boundaries, this is an adult crowd, but I'm only going to focus on the adult hospitalized patient, or practice within the adult hospitalized patient. Why do I say that? Because this guideline is 40 some odd pages, contains a lot of data. It contains detailed statements on institutional guidance around epidemiology, control, terminology. I'm not going to address all that. I'm not going to address any of the pediatric issues either. So again, only focus on the guidance for the adult hospital medicine practitioner. So testing. So how do they define it? I think this is an area where, there is some debate, but what they come down and say is, in general, as a weak recommendation based on very low quality of evidence, when should we think about it? Greater than 3 unformed stools in 24 hours in the absence of another good cause. They also come down with a strong recommendation in moderate quality of evidence around testing. Do not perform repeat testing on the same episode of diarrhea within 7 days. If you got a negative result and the diarrhea continues and you're using a high quality testing assay, don't go back and say, let's retest. They're coming down very strongly against that. There is some nuance within that at the individual level. Prevention and control. So I think something we've all sort of seen and I don't think is very shocking to any of us. They are recommending with a strong evidence or strong recommendation, moderate quality of evidence, place patients in private rooms with dedicated toilets. Strong recommendation, high quality of evidence, wear gloves. Gown, which I know institutionally we do across the system here, strong recommendation, moderate quality of evidence, not as good for gowning. And they say this should be done by healthcare personnel. Continue contact for at least 48 hours after the resolution of diarrhea. Strong recommendation, but not the quality is not as high as previous recommendations. And then, they still come down and they say it's okay to leave people on contact till discharge if your institutional rates are high enough to cross the threshold where infection control thinks you should do this. They come down as a weak recommendation, low quality of evidence, but it is in there. Hand hygiene. So what should we do? I actually did find some of these a little shocking. So for routine or endemic sort of levels of C. diff in your institution, hand washing with soap and water or an alcohol-based hand sanitizer may be used after removing gloves. This comes down strong recommendation, moderate quality of evidence. And that's for average rate. If you're experiencing an outbreak or what they term hyper-epidemic settings, then we should only wash with soap and water. Weak recommendation, low quality of evidence. Handling feces, they're saying you should wash your hands. There's no evidence for this. Good practice recommendation. This is one where I'll just go, yeah, expert opinion, probably, yeah, that's a good idea. Patient bathings, they're saying patients should wash hands or shower to reduce spore on the skin. Again, no one studied it. if anybody wants to, might be a way to get a novel paper out there. Also a good practice recommendation. So in the end, wash your hands. It's good for you. Mom was probably right. You should do it after you go to the bathroom. So, or touch other people's poop. So, so that's the hand hygiene. What about asymptomatic carriers? Not enough evidence to recommend screening for carriage or isolating asymptomatic carriers. For those that have read into this area, you'll know there are a number of papers that do come out strongly for this, but the guidance is that it has not crossed a recommendation level threshold for IDSA. Antibiotic stewardship, strong recommendation for with a moderate quality of evidence that we should minimize the frequency and duration of high-risk antibiotic therapy and the number of antibiotic agents prescribed to reduce CDI risk. Another good practice recommendation, implement an antibiotic stewardship program. And then antibiotics should be targeted based on the local epidemiology and the C. diff strain's presence, meaning, really we know which drugs are the high sort of culprits or those that select for more deadly strains of C. diff. And so they really sort of do specifically mention restricting fluoroquinolones, clindamycin, and upper generation cephalosporins, except for as antibiotic prophylaxis should be considered. And they say that this is a strong recommendation, moderate quality of evidence. Contributing factors. So I know many of us talk about PPI use. They come down saying that this association is there and we should discontinue PPIs if they're not needed. But the data is really not there for a broad, all-out sort of banning of PPIs in people with C. diff or those that you consider to be high risk. So they gave no recommendation. They also gave no recommendation to probiotics, which we know the meta-analysis have gone back and forth on their effect on C. diff and prevention of C. diff. Treatment strategies. So we should stop antibiotics as soon as possible, but not before that. Before we can, as this may influence C. diff recurrence. That's a strong recommendation, moderate quality of evidence. And then antibiotics, what about empiric treatment? You're waiting on the test. They're saying if you think there's going to be a delay or the patient looks sick enough, go ahead and start. If you know you're getting the test back in an hour and the patient doesn't look critically ill or what we would have previously termed severe C. diff, which is now called fulminant CDI, then maybe you can wait. It's all guidance and it's based on a weak recommendation, low quality of evidence. So here's where I think the punchline is that many of us have been waiting for. So what do we do for that first episode? Metronidazole, aka Flagyl, if you're still using brand names, out. What's in? Vancomycin or fidaxomicin for everybody if it's available. They do have some caveats. If it's not available, then you can still use metronidazole. Strong recommendation, high quality of evidence. The dose for standard C. diff, not fulminant C. diff, vancomycin 125 milligrams orally 4 times a day, fidaxomicin 200 milligrams twice a day. Both of these regimens for 10 days. This is the big takeaway. If you think about C. diff, it's one of these two agents, not metronidazole anymore. So fulminant C. diff, previously known as severe disease C. diff. They're recommending, in this case, really vanc first line, high dose, 500 milligrams 4 times a day. Strong recommendation, moderate quality of evidence. If there's an ileus, they also think you can use vancomycin retention enemas, 500 milligrams in some normal saline every 6 hours can also be administered. But this is a weaker recommendation, low quality of evidence. And then intravenously administered metronidazole should be given with oral or rectal vancomycin, particularly if ileus is present. Strong recommendation, moderate quality of evidence. And this is the 500 milligrams of metronidazole every 8 hours that we all know and love. Surgery, So they do recommend it if needed. Subtotal colectomy with preservation of rectum is the strong recommendation, moderate quality of evidence. Diverting loop ileostomies with colonic lavage followed by antegrade vancomycin flushes. Alternative approach that may lead to improved outcomes if you want to try and preserve the colon. It's weak recommendation, low quality of evidence. They come down as the subtotal being the first line. First recurrence, I'm going to kind of go through this a little quicker just to kind of go over it. So for the first recurrence, they don't get into what is tapered and pulse regimens. They don't recommend, there are a number of them out there, just to know that a 10-day tapered or pulse regimen is now preferred over a 10-day standard second course of vancomycin. If you got vancomycin the first time, weak recommendation, low quality of evidence. Fidaxomicin rather than 10 days of vancomycin is also okay. Same weak recommendation, but a moderate quality of evidence. For those who got metronidazole, standard 10-day course of vancomycin is still your first choice. Weak recommendation, low quality of evidence. What about that second recurrence? The dreaded second, third, fourth recurrence, right? This is all the same for whichever recurrence past recurrence number one. Options, again, another tapered or pulse regimen of oral vancomycin, standard course of oral vancomycin followed by rifaximin or fidaxomicin. Again, all of these are weak recommendations with low quality of evidence. Oddly enough, strong recommendation with moderate quality of evidence is the fecal microbiota transplant, sort of making it in there. If you failed for that second time, it's up there. It's getting up there earlier in the regimens. And then where there's insufficient data or no recommendation is just these really long treatments beyond the recommended treatment. They give no recommendation. What do you do? Somebody had C. diff last year and now you got to give them antibiotics. Do you just prophylactically give them vancomycin again? They stay out of it. They leave it to, at this point, what we would call provider preference. And same for people who require antibiotics shortly. Like last week, you finished your C. diff treatment. What do you do when you need, something for the pneumonia today? Don't know. So take home here is oral vancomycin because you're thinking C. diff. So next gentleman is a 67-year-old man who's in the hospital for left heart cath and just had his Foley catheter removed when he suddenly develops 102-degree fever. His breathing's labor at a rate of 20 breaths per minute, and his heart rate's 103 beats per minute. You're called to the bedside. You're asked to start the sepsis protocol. You start IV fluids, broad-spectrum antibiotics. The nurse asks you, should we get all this in 1 hour? You reply, nah, 3 hours is what we do. It's fine. Yeah, that sounds good. What the heck? Quicker's better. Yes, 1 hour is the new goal. I'm not sure. Let me call the sepsis hotline. So I usually go for D, call a friend. So surviving sepsis campaign focused update 2018 came out last year. So in this article, I want to say it was like March-ish. I'm sorry. I forget when. It was early in the year, though, in 2018. The Surviving Sepsis campaign, based on reevaluation of all the old data that caused them to come out with the 3 and 6 hour guidelines, said 1 hour should be the new guideline. Time 0, time of presentation is still time at the ED or first annotation in the chart. So 1 hour is where they thought we should be responding to sepsis and implementing this bundle of measuring lactate, obtaining blood cultures, administer broad-spectrum antibiotics, administer 30 milliliters per kilogram of crystalloid fluids for hypotension or lactate, or apply vasopressors if the patient's hypotensive after fluid resuscitation to maintain a MAP of greater than 65 millimeters of mercury. As you can see, some of these are very strong. The lactate's actually a weak recommendation based on some low quality of evidence. The others are low and moderate quality, but really pretty strong recommendations. Well, as you can imagine, saying we need to do all this in 1 hour or you failed the sepsis guideline, it was a pretty strong statement that caused a lot of pushback, particularly from our colleagues in the ED, as well as some people not on the Surviving Sepsis Campaign Committee. So there was a lot of outcry about this. The SSC and the American College of Emergency Physicians issued a joint statement on January 9th, 2019, placing the guidance for a 1 hour bundle on hold. Then on the SSC website, you can see that the January 10th, as of a day later, they reasserted support for the 1 hour bundle as a target goal, but not a mandate. What they've changed is this statement from the 1 hour bundle to the first hour of the bundle. Sort of taking the language down a notch, and they're saying we really think everyone should implement this in an hour, but 3 hours is still our goal. We should all check with our own local guidance around what is our goal and what do we consider our target. So in the end, maybe not. Sort of not a great answer in this one because it was the answer, then it wasn't the answer. So, So a less controversial one. So now our guy's better. He's ready to go home when he suddenly becomes short of breath again, has visible labored breathing. It's brought up, oh, by the way, he had COPD and nobody med-raced him and got a good history. So he hasn't been getting his usual inhaled corticosteroid, LABA, and LAMA treatment at home here in the hospital. An ABG is done. It shows a pH of 7.302 and a PCO2 of 51. You call respiratory, and the respiratory asks you if you want non-invasive mechanical ventilation or not. You reply, hey, sure, that sounds good. Always a good answer. B, no thank you, just some nebs, please. C, I would, but I don't think he meets the criteria. D, well, perhaps we just discharge him and have him go to hypercarbia clinic, right? That you guys started that up here, right? No? It's not next to pre-op? Okay. So I thought it was. Somebody told me. I read it in a newsletter. So I like this guideline. Why? Because it's a European and American society. They come together to give this clinical practice guideline for non-invasive ventilation for acute respiratory failure. It's a little older. It goes back to 2017, but I think still really a good one. Why? Because who's taking care of this guy? Right? You put the BiPAP on him, keeps taking it off. Put it back on him, keeps taking it off. No? Nobody's seen him? Okay. All righty. So non-invasive ventilation for acute respiratory failure. So again, as I said, it's a combination effort by the European Respiratory Society and our own ATS. What I also really liked about it is they used, in their recommendation, they ask it, it's like a question answer and you kind of get to play along with them. They used a population intervention comparison outcomes, or PICO style questions to address the clinical content. There's a lot of material in the supplement accompaniment as well. So if you do go to the original paper, just recognize there's a lot more to go to as well. They didn't address some of the topics because there's just a lack of evidence. And as I said, it's the paper itself is a question and recommendation. So some of these will look like questions because I took it from there. Should non-invasive ventilation be used for acute respiratory failure due to COPD exacerbation to prevent respiratory acidosis? So in this area, this is for the patient without respiratory acidosis at a pH of greater than 7.35. Their answer is no. They don't think you should do it to sort of prevent them from getting into extremis. This is patient not yet in extremis. It's a conditional recommendation, right? So that's the same as weak, but they call it conditional here. Low certainty of evidence. What about our patient who has established acute hypercapnic respiratory failure due to COPD? Right, this is a patient, so how do we judge this? Because many of our patients do live with a PCO2 that's a little elevated, so we should really be looking at that pH. They're saying if they're breathing fast and you think their pH is due to, or they're having labored breathing, and the pH is due to is less than 7.35 due to the COPD exacerbation, then yeah, we should do it if there's the respiratory acidosis. This is also all based off of ABG data, not VBG data. I know that we often use VBGs now in clinical practice because they're quicker, they're easier, they're a lot less painful to the patients, but should we do it? Strong recommendation, high certainty of evidence. All right, and they recommend a trial of bilevel non-invasive ventilation for patients considered for endotracheal intubation, unless you really think you need to intubate them. They do say if you think you need to intubate them, intubate them. If you think you want to give them a little trial because they look like they're getting a little weaker, go ahead and do it. Strong recommendation, moderate certainty of evidence. What about in heart failure, pulmonary edema? Should non-invasive ventilation be used in heart failure in respiratory failure due to acute cardiogenic pulmonary edema? They recommend BiPAP or CPAP for acute respiratory failure due to CHF. Strong recommendation, moderate certainty of evidence. Should you try non-invasive ventilation prior to the hospitalization to prevent further decompensation? They suggest, maybe it could be used. I know that doesn't really affect us, but if you start hearing about our emergency services implementing this in the field, they do give it a conditional recommendation with low certainty of evidence, but they suggest that we should do it or consider doing it. Acute asthma in adults. I know that it's a little confusing who has asthma, who has COPD. There's a little confusion around this, but for those patients with childhood asthma who've now made it to adulthood asthma, should we use non-invasive ventilation for acute respiratory failure due to acute asthma? So they actually come down, they say there's not enough data to really make this recommendation. There are a lot of papers studying physiology around it, but they don't consider that clinical outcomes. There's not a high rate really of what we can term adult asthma causing acute respiratory failure to this degree where you need to consider non-invasive or invasive mechanical ventilation. In one large paper, or one retrospective paper with over 13,000 patients, when they looked at all the patients who came in with asthma exacerbations, over 13,000, only 4% were given non-invasive ventilation. There was a very low failure rate. Only 26 of those 4%, which is about 500 patients, wound up needing intubation. And then only about 5% needed invasive ventilation. When you compared them, the outcomes, even those that failed, were pretty similar. So given all of this, they don't really make a recommendation. What about post-extubation acute respiratory failure? I know that we may not be in the ICU watching these patients right away, but we do manage them if they transition to the floors very quickly. So for patients at high risk of respiratory failure, they suggest it should be used. Again, a lot of these are sort of weak recommendations or conditional recommendations with a low certainty of evidence, but they do suggest these following statements. So they suggest that we use it in high risk. They suggest we not use it in low risk patients. And they suggest that non-invasive ventilation be used for weaning for patients with hypercapnic, not hypoxic. They make no recommendation about what to do for hypoxic respiratory failure. Other conditional or no recommendations, I think that sometimes, these are more often the patients, I know you all do a lot of perioperative management, as does the group down at Beth Israel. What about using it in the post-op setting of acute respiratory failure? They suggest using it for post-op acute respiratory failure. Conditional recommendation, moderate certainty of the evidence. What about those immunocompromised patients who are going into respiratory failure and you're not sure of the cause? Again, they suggest using it. conditional recommendation, moderate certainty of evidence. Palliative care, for our patients that, for those that do some palliative service, for those of us that are taking care of patients, they haven't really transitioned off our service, but we're moving them more towards comfort. They suggest using it in the setting of a patient who's dyspneic with a terminal condition. Chest trauma, this one I found a little shocking. I've had a few people that, were having some trouble breathing with broken ribs recently. They actually suggest using non-invasive ventilation to try and prevent going all the way to invasive recommendation. And then what about people, you have no idea what it is, they're immunocompetent, they're just going into it, they have no recommendation, they don't know what to do with it. So sort of, you may try it, you may not. I don't think anyone knows what to do. Flu. Who saw the flu last year? Yeah. So what do we do, right? Those patients, they can get really sick, they can turn on you. So there's no recommendation about what to do in pandemic viral illnesses. This is where I throw the flu. There's only observational studies. And why do they not recommend anything? There's just high failure rates no matter what you try. As we all know, when patients go into interstitial lung injury, there isn't much to do other than supportive care, and this doesn't seem to turn them around quick enough. So they didn't say anything. So what did I say for this? I said, sure, sounds good. He meets the criteria. pH is a little lower. CO2's up. Sounds good. Let's BiPAP. All right. Last recommendation. 72-year-old woman is in the hospital being evaluated for syncope. Her abdomen's firm on morning rounds, and she tells you she hasn't moved her bowels in like a week. She's on some short-acting opioid pills for a vertebral compression fracture. The nursing assistant asks if there's anything we can do to help her. She has a lot of straining and no bowel movement earlier that day. You say, let's start some oral laxatives to stimulate her bowel movement. It's probably her heart medicine. Let's just stop those. Sometimes we like to pick on those. Or we can use one of those new anti-opioid medications, right? You guys have some of those up here too? We love them. But so this guideline came out just this year, actually. This is my January study, right? So I told you we'd go up to it. So we hit our mark. AGA came out with a guideline on medical management of opioid-induced constipation. I think it's something we all struggle with. What's the best thing to do? Here, some more poop. But this poop's, he's a little more sad. More sad because it's constipated. It's hard. He wants to come out. So why don't we start with what is opioid-induced constipation? So the simple definition is you're constipated because you've been taking some opioids. The more complex Rome 4 definition is new or worsening constipation occurring while initiating, changing, or increasing opioid therapy. So do you have two or more of the symptoms? 25% of the time are you straining? Do you have lumpy hard stools, incomplete feeling of evacuation, anorectal obstruction or blockage with 25% of the time? You need some manual maneuvers to get it out. Or do you have fewer than 3 spontaneous bowel movements a week? Here's the classes. I'm just going to go over them all. I think that you may all be familiar. There's osmotic laxatives, PEG, lactulose, mag citrate, magnesium hydroxide. They draw water into the intestine and soften the stool. There's stimulant laxatives like bisacodyl. They irritate the sensory and nerve endings to stimulate colonic motility. I can share this one with you, Marianne. Well, maybe not you. Maybe someone else in the group asked me. They can share it with Marianne. So Barno left. I wouldn't let him have these either. Detergents, stool softeners like DocuSafe. I know around here that's a dirty word, but it still makes it onto the AGA's little chart. Lubricant, laxatives, mineral oils, like sort of our big one. Then there's what they call the PMORAs, the peripheral acting mu opioid receptor antagonists. There are 3 of them. They all block the mu receptors in the gut, thereby restoring function. There's some intestinal secretologues, like lubiprostone. They act on the chloride channels, or the guanylate cyclase receptors to stimulate fluid secretion. And then there's the selective 5-HT antagonists, and they activate the 5-HT4 receptor to increase colonic motility and increase transit. So what do they say? What should we do? They come down really strong. Laxative, laxative, laxative. Strong, moderate quality of evidence. First line agents. Should you fail these, they say you can go to the Pomoras for refractory to constipation, refractory to laxatives. They recommend them in an order here. Natamidine over no treatment, strong, highest quality. Nagoxol, sorry, having some trouble with my enunciation today. Over no treatment, also a strong recommendation, moderate. And then methyl naltrexone over no treatment, really conditional and low. Intestinal secretologues and the 5-HT antagonists, no recommendation. They claim for both of them there's really an evidence gap at this point. So for the last case here, start oral laxatives to stimulate a bowel movement. If that fails, then probably go to the anti-opioid medications. It is, of course, always good to think about the heart medicine, but, you know, if you're on the opioids, let's attack those first, because probably the heart medicine you've been on for a long time is probably not causing new constipation. So that is what I have to say. Thank you and for your time and sharing it with me today.